This is the first webinar in a series of webinars, Hindsight is 2020, what we've learned about COVID-19. Today's webinar will be on systems of care related to COVID-19. Next week's webinar will be on bedside care. And finally, on December 17th, we'll have a discussion about ethics, research, and communications. My name is Chris Carroll. I'm professor of pediatrics at Connecticut Children's Medical Center and a pediatric ICU physician. It's my absolute pleasure to moderate this session. We've got a fantastic lineup of speakers today. Up first, and why don't we just go ahead and get started? Up first will be Dr. Mangala Narasimham. She's going to be presenting today for the first talk in our webinar, and then we'll have questions and discussions at the end. So I will turn this over to Dr. Narasimham.
Thank you, Chris. I appreciate it. I'm Mangala Narasimhan. I work at Northwell Health in New York, and I'm the director of the Acute Lung Injury Center, the VV ECMO Center, as well as a professor of medicine at the medical school. I'm going to talk to you about ICU organization and the lessons that we learned. Our hospital system was hit very hard in March and April, and we were, I think, the epicenter of what was happening in New York at that time. So I'm going to talk to you about some of the things that we went through and the lessons that we learned in the hopes that they will help you going forward. Next slide, please. So we were prepared. We had heard about China. We had heard about Italy. We had several discussions and phone chats with the doctors in both China and Italy. And we had a command center set up, and we were planning for what we thought was coming starting in mid-January. We had weekly meetings, and we discussed surge planning, and we discussed 10% above capacity and 20% above capacity, where we would put these beds, and we ordered extra ventilators on rental, extra dialysis equipment, extra ECMO equipment, just getting ready for what we thought was coming. And our division had multiple meetings discussing treatment algorithms and what we thought we were going to do with that. Surge plans for the ICUs, how are we going to staff them, where are we going to put them, and what supplies we would need. And we really felt good that we had time to prepare after what was happening in Italy. And we thought that could never happen to us. We're the United States of America, and we have a different medical system, and they were overwhelmed, but that's because they're in Italy. So that was sort of the mentality going into March as we were preparing for this. Next slide, please. And then we got hit, and we got hit not just a wave, but like a tidal wave. Next slide. This is how fast our admission numbers rose. So we would be in the hospital and listening to overheads in the middle of March and hear about every 20 minutes an anesthesia call and an intubation. And we were filling up our ICUs to the point where we were getting about 20 to 25 patients in a 24-hour period. And we were doing this for about 3 weeks straight. So at our max, our hospitals, we have 2 tertiary hospitals that my direct group oversees, had about 900 patients each with COVID in them. And of those 900 patients, about 200 patients were intubated at each of those hospitals. So every possible space was taken to take care of these patients, and the rapidity with which this happened, you can imagine. We had, within a month period, over 13,000 patients that we took care of with COVID in March, April, and May. And that's how fast it rose. And the discharges obviously did not happen very fast. Anyone who's taken care of COVID knows that their length of stay is longer than our normal ICU patients, and their hospital stay is longer. And so our ICUs were filling much more rapidly than we were getting patients out of our ICUs. So this created a huge problem for us. Next slide, please. And this is again, the rise that we saw in the rapid amount that had happened. And this is the number of total ICU admits that we had daily, basically, over that time period. Next slide, please. So this is the total number of ICU patients that we took care of in the first surge. These are intubated patients, and you can see the number that are deceased and recovered. This was looking back sometime in June, looking back to March, April, and May. Next slide, please. And the average age was about 66 years old, so not very elderly people at all. And next slide, please. And the number of days on the vent was around 12 days, much longer than regular ICU patients. Our normal length of stay in the ICU is about 3 to 4 days in our ICUs. So this is obviously 22 days in the hospital and 12 days on a ventilator, and that was our average. So this was a real space issue, a person power issue, and nothing that we could really truly be prepared for in any way, no matter what we thought we were going into. Next slide, please. The comorbidities that we saw, it was really respiratory failure. They were mostly pneumonia patients. Some of them were acute renal failure with electrolyte disorders that needed acute dialysis. And that was the large majority of them. So they were all intubated, all of the ones that made it to the ICU. We really had no patients in the ICU that were not intubated in ARDS. So it was large numbers of patients and very critically ill, not our usual mix of patients waiting to leave the ICU and patients waiting for a transfer and patients waiting for, acute dialysis because they were on BiPAP. This was very different. These were very sick patients that really needed a lot of care. Next slide, please. And the patients who died pretty much died mostly of respiratory failure, renal failure, and that was the big two diagnoses that we saw in the patients who did not survive their COVID stays. Next slide, please. This is what our ICU space looked like. This is our PACU, normally a space that is less crowded. This was about 50 patients in one open space. And we did this with many places in our hospital. You could see that they tried to wall off the central nurses station so that people would have some respite from the open space, but really it was very difficult to do that. So people spent 12 hours a day, every day in these units that were just these big open units. We had no ability to house patients in single rooms after the first week of this going on. So patients were everywhere. We had our auditorium, the seats were ripped out, and we turned it into a patient care area. Our cafeteria was prepared to be a patient care area. We had several tents, industrial tents put up outside to help us take care of patients. And this is how we got through this with the 900 patients that we had at one time. Next slide, please. So what were our issues? It was the patient volume, number one, the rapid ascent of patient volume, the doubling time of patients and ICU admissions were very short. So we had to create new teams pretty much every day to take care of ICUs. So very quickly we ran out of critical care teams. What we started to do is we put our critical care teams into the new units that were being built. Patients were very unstable when they first came in, and then they sort of stabilized out. So we would have our critical care doctors in those new units as patients were coming in. And 24 hours later, we would move our doctors to another unit and let them start another unit. And we would give that relatively stable unit to another group of doctors that were not critical care that we deployed from other parts of the hospital. So we had hospitalists, we had cardiologists, we had GI doctors, we had cardiothoracic surgeons running an ICU. We had pretty much anyone that we could get. We had dermatology residents as our support staff. We had pediatrics people. Our PICU team took over one of the adult ICUs in our system. So we recruited everyone that we possibly could. We stabilized the patients, and then we gave them to a team of doctors. And then every day our teams went around and we made vent rounds on 200 patients 3 times a day. And we adjusted the ventilators. We tried to help with management overall, and then we would move to the next unit and do the same thing. And this is how we tried to help out and still keep people standing, basically. And that we did this over and over again for many weeks. And looking back, the one thing that I would say is I really wish that we had more critical care doctors. I think that patients would be served better. These were complicated vent management patients. And I think that the struggle was sedation issues. The struggle was plateau pressures, driving pressures, proning patients appropriately. And that you need a critical care doctor to do. So as much time as we tried to go around doing vent rounds, the struggle was what happened 2 hours later and what changes were made. And we would continue to just circle the hospital and round on as many patients as we could. And we would always try to put the non-critical care teams in some physical proximity to the critical care team so that we could help out if there were emergencies. But it was difficult with 200 patients in each hospital. We were spread out then over 3 different hospitals trying to cover all of those patients. So it was about 500 patients at a time that we were trying to cover at our max time that we were doing that. ICU space, just constantly finding new safe places, putting monitors up in places that didn't have them, and finding space to put patients that was safe. We gave up on negative pressure very quickly. There was just not enough of it that we could do. And load balancing, we moved patients around. Some of the hospitals in Queens got hit very hard early on and had patients waiting in the ER, intubated, not doing well. So we started moving patients out to our hospitals in Westchester, our hospitals out east, many miles from the epicenter that were less busy at that time. So we moved about 900 patients around into the different hospitals, just trying to fill hospitals that were less busy with sick patients so that they could get better space and better care. So we did a lot of that. I think that saved a lot of people's lives. It was hard to move critically ill patients just as they came in, but there was no place to put them in the hospitals that they were showing up in. So that was something that I think really did help. Caregivers trying to train people, do boot camps for ARDS with large groups of people as we set them out to deploy them into these ICUs. We tried to do that as much as possible. And then supplies. We would meet every day. I would get on a call with procurement and say, these are our hotspots. How many ventilators do we have left? Who's going to get hit tonight? Is it going to be this hospital, this hospital? And we would guess and say, this hospital probably needs 20 ventilators. And we would move them from a slower hospital that was not as busy by truck every night to a hospital that was getting hit very hard. And we managed to stay afloat with FEMA ventilators, our ventilators being moved from hospital to hospital. But every day it was a stress of, are we guessing correctly? Do we have the right hotspots? You know, what's going to happen if we guess incorrectly? So that was a very difficult thing to do. And we did that every day at the end of the day to make sure that at night they had enough ventilators for each place. CVVHD machines were another thing. And we started doing SLED in large groups of patients instead. We ran out of supplies for CVVHD and we ran out of dialysis nurses. So we tried to cohort patients in one unit that would need dialysis, a big open unit. And so the dialysis nurses could watch many patients at one time and tried to make it a little more efficient that way. All of us ran out of medications. You know, that's not something that was unique to us, but paralytics and sedatives were in short supply. So we tried to get by with what we could and use things that we would not normally go to as first-line therapy. And then high flow and non-invasive. In March and April, we really weren't sure if they were safe. We weren't sure if our N95s were going to work. Everybody was very nervous about doing this in non-negative pressure spaces. So we ended up intubating a lot of people. Now we're doing a lot more high flow and non-invasive. And I'm still not 100% convinced. It's good for some patients, but the patients who linger on 100% high flow and switch back and forth with bi-level, I think their pleural swings and pleural pressure swings are really still very high. And we may not be doing them a favor long-term because those patients, those particular subset of patients are still getting intubated late in their course. So that was something that we struggled with as well in the very beginning. Next slide, please. And again, standardizing care, the GI doctors, the cardiothoracic surgeons, the cardiologists, the critical care surgeons, you know, all wanted to do things differently. And everybody thought this was some special ARDS that was different because that's what the internet was saying. So that battle of trying to do good critical care, standard ARDSnet care was a constant battle for us, and that we were trying to go around and fix that all the time. I told you about vent management, sedation management. People wanted to do no sedation, and people wanted to do very little sedation, and people wanted to do 10 different sedatives. So just trying to get that into some orderly fashion as well was a struggle. And then there was a treatment struggle. We didn't know what to do. We would meet every day as a group, the critical care team, and say, what's out there today in the literature, what have we read about, and we would talk about treatment. And every ICU and every one of our hospitals was doing different things and different amounts, and tocilizumab and IL-1 and steroids, and we were arguing about what treatments to give and hydroxychloroquine or not. So that was a big stress, I think, for the teams, because we weren't aligned, and everyone sort of was reading something and wanted to try it and had anecdotal evidence that their friends said it was working. So struggling with that treatment algorithm. So I think if you can get that straightened out and at least within your own group agree that this is what you're going to do, I think that will take a big stress off of your teams. Team structure, who owns the resources of the ACPs across the system, and who owns the residents, and how can we move people around? We had to break down a lot of barriers and silos to move people to where we needed them rapidly. And that was a difficult thing because everybody works in their own little world. And then all of a sudden, when things got a little bit better, everybody wanted to pull back to their units and go back to cardiac surgery and go back to endoscopy and do all the things that they were doing. And then we were left running many more ICUs than we could handle at the very end. So I think remembering to keep teams where they need to be for as long as you need them is also a key thing. And then research, we were trying while all this was happening to do trials and to get information out there for the rest of the country. And that was very difficult to do while we were, struggling to stay afloat and really drowning what we were dealing with. And now we're dealing with the issues of burnout. The first time it was exciting and it was sexy to be in New York when all this was happening. But now, knowing what we knew and being exhausted 6 months later, people don't want to do this again. So as we go back into this now, we're dealing with the burnout issues and just the physical and mental exhaustion of been now, 6 or 8 months of doing this. So that's my story in New York at Northwell, and hopefully that will help people out there.
That was great. Thank you. I'm looking forward to our discussion at the end of this. I really appreciate you describing your experience in New York, which sounds like you did a spectacular job holding that whole group together. So thank you. Next up is Dr. Geneva Tatum, who is going to be talking about changes to medical education over the last year.
Thank you so much, Dr. Carroll. Yes, I'm the Fellowship Program Director of Critical Care Medicine and Pulmonary Critical Care at Henry Ford Hospital and Associate Professor of Medicine. And so I just wanted to spend a few minutes just talking about some changes in medical education during the pandemic. Next slide. I think that there were some key things that all of us in medical education around the country learned. We certainly learned one very important thing, which was that our trainees had a degree of resilience and adaptability that we may not have initially predicted. But I think we also recognize that now, as we are entering into the second phase or the second wave of this pandemic, if you will, or for some even the third, that they're starting to lose some of that resilience. We're concerned that may be an ever increasing problem with burnout as we kind of move into this very long phase that we anticipate during winter. One of the key things that I think many of us learned was really a focus on psychological safety. And that's a term coined by Dr. Amy Edmondson at the Harvard Business School that really talks about the climate in which people feel comfortable sharing concerns and mistakes without fear of embarrassment or retribution. And for those who may be medical educators on the line and know about the ACGME survey in particular, that's actually a question that we look at under resources on the survey. It's not quite worded that way, but that's what it's really trying to get at. And so if we think about what we've all experienced and all we've seen within COVID, we know that patient safety and provider safety is a key element of being able to provide effective care. Our trainees were in a unique situation in the sense that they are both learning, but they're also trying to develop skills that are necessary for them to be, technically competent and very proficient in providing care. And so being able to create an environment where they not only felt safe to speak up about issues that concern them around patient care, but more importantly, issues that concern them around their own personal care and personal safety was really important. All of us spent a fair amount of time making sure that there was appropriate education in PPE, donning and doffing. It's a simple concept, But if you're not careful about it, you can actually self-contaminate. And so making sure that our residents and our fellows were really comfortable and really understood how to do that properly and correctly, and having buddy systems initially to make sure of that was a key element to that. And again, I think, really having a lens on psychological safety really allowed our teams to grow dynamically and also allowed them to create trust and respect among themselves and to diffuse that amongst teams as we rapidly expanded. We had the same rapid expansion as they did in Northwell, not to the same degree, but certainly in a very, very rapid ramp up. And we found ourselves having to build teams, of very different background experience, very different in training. And so we had to have a sensitivity to team structure and a sensitivity to our trainees that may be coming from other backgrounds like neurology or dermatology and really were unfamiliar with the critical care environment as well. And so being able to allow our fellows to leverage their skills that they have in critical care medicine to educate their peers or their junior trainees within principles of ICU care was incredibly important. That allowed them to solidify their knowledge, but it also allowed us all to extend our scope of critical care education within the institution, which was essential in order for us to provide adequate care for our patients. I think it goes without saying there, had been a lot of emphasis in terms of the changing ways in which we teach. Certainly what we have to teach has remained static, but the methods in which we do it are constantly in evolution. And I think the pandemic has taught us a fair amount of innovation in order to meet educational needs. And so we learned how to incorporate technology that we may have been using in small ways and really had to rapidly adapt that and adopt it so that we could be effective in our teaching. I think it goes without saying that there has been a tremendous amount of synchronous and asynchronous virtual learning, due to fellow deployment and resident redeployment needs and changes. And so all of us around the country had to pivot very quickly to incorporate technology in order to allow our trainees to still learn while actively either being deployed or being away from clinical care. And so rapid updates in literature were very important, providing them references, providing them updates in terms of what our policies and procedures were and our best practices were. And I think one of the things that we're now focused on as, again, we're in the setup for the next wave is really thinking about the ACGME's focus that they have set for us in terms of competency-based medical education. I think for those trainees who already experienced that first wave in March, April, May, who are now continuing training and are now faced with, again, another surge, it's incredibly important for all of us in medical education to really focus on their clinical competency. And so the ACGME actually has put on their website some guidance around that in terms of assessing progress and identifying competency gaps. It's incredibly important, when I think about my critical care trainees in particular, who spent an inordinate amount of time providing, medical critical care. Essential to them being deemed competent is also understanding and being able to provide care for non-medical patients, surgical patients, neuro ICU patients, et cetera. And so having a sensitivity to those experiences that they may have missed at the end of last academic year and ensuring that they are provided those opportunities is incredibly important as they move through this academic year. I think the other thing was really having a great opportunity to collaborate across institutions. We do tend to work in silos, but this really allowed us to break those barriers down. We found that we had to connect among programs. We had to connect with our national organizations so that we could have some repository of reliable data and reliable literature that we could use, and use that to help learn from one another. Our trainees are very technology savvy, very app savvy in particular. And so they set up Facebook groups and WhatsApp groups in order for them to share learning and share protocols across programs. And many of us in our training programs, had virtual conferences on a regional level, which allowed us then to collaborate across institutions within the region and provide some learning opportunities for fellows at smaller programs that may not be able to get as much as the larger programs have. And I think, particularly when it comes to synchronous and asynchronous learning, I think one of the things unique in critical care medicine is, in particular, are the procedural needs. And so learning how to deliver content around procedural competency and being able to observe and assess that was really important. Next slide. What you'll see here is actually part of our regional bronchoscopy simulation that we had earlier in the academic year. And what you're seeing is actually some of the things that we did to allow for procedural training and simulation in real time. And you have an instructor and a learner who actually are facing away from each other. Again, allowing for a little bit better social distancing. They both have masks. And this was really important to us because, again, there are a lot of things that limit our ability to have large numbers of learners together in one room. And so this was, just one simple way of doing it. Next slide. And then again, you'll be able to see, again, social distancing, mask wearing, all of the things that are necessary to keep trainees safe as they're learning hands-on procedural education. Because again, there are some elements of what we do that cannot be redemonstrated or done virtually. There needs to be live hands-on training and direct observation. And this is one way that we were able to do it. And it was a really great opportunity, again, for fellowship programs around the state because this was a regional conference. So those smaller programs that didn't have the technical equipment, the resources really to provide this type of training, we were able to provide for them, which I think was, again, a great testament to our ability to do institutional collaboration throughout the region. Thank you.
Thank you very much, Dr. Tatum. That was excellent. So next up is Dr. Hagab, Sarah Hagab, who is going to be talking about how some of our visitation policies have changed some of our patient and family-centered care that we typically provide. Dr. Hagab.
Thank you, Dr. Carroll. Next slide. So patient and family-centered care is a kind of cornerstone of our approach to providing care for patients. And patient-centeredness is a term that was invented, so to speak, about 2 decades ago, and is defined as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patients' values guide all of our clinical decisions. So part of being able to deliver patient and family-centered care is including the patient and the family in all of the decisions that we make. And part of that is welcoming them into the care setting. And so many years ago, this idea of limited visitor hours in hospitals really has been eliminated. with the focus on improving access and transparency and families' ability to be at a patient's bedside. Next slide. So the challenges that presented themselves with COVID were that we were faced with a highly contagious novel virus. The early risk factors weren't really clear. So we weren't sure who was more at risk for developing this disease, who was more likely to become infected or not. What were the risk factors for developing more severe disease versus less severe disease? So we were really dealing with many unknowns, and in some ways still are. Contagiousness, obviously, when you're dealing with a pandemic and an infectious disease is of utmost concern. And so how could we best protect families? How could we protect our patients? How could we protect other patients in the hospital who may not be admitted with COVID? And how do we protect our staff? There was also kind of on the forefront of everyone's mind, PPE shortages nationally. We are in a better place now than we were early on in the pandemic, but we were struggling to provide enough PPE for caregivers in the hospital and healthcare providers. So how could we manage to bring more people into the hospital? And so for many of those reasons, we changed our policy. Next slide. To a no visitor policy. It's important to remember that during any crisis, the need, just from a psychological and emotional perspective, the need for connectedness increases. And so I want you to take a moment and look at these pictures, which were published in various newspaper publications throughout the pandemic. And I'm sure they look very familiar to everybody on this call. The gowns, the masks, the shields. So they are physical barriers that were there, yes, to protect us, but they were barriers between us and our patients. Imagine being a patient who is sedated, who may have altered mental status in the hospital, who does not have any familiar person around them. And this is what they see every day. And so it's very hard to connect with those taking care of them. And sometimes, and I'm sure, can be very scary. And so people started to get creative. There was a need on our part as providers, knowing that that connection is so important. There was a need to maintain that connection. And so people started to think of creative ways in order to kind of break down some of those physical barriers that were there. So you had people who print hospital systems that printed pictures of healthcare providers, and they could be worn outside of their gowns so that patients could still see and feel the kind of that human connection with the person that was caring for them when they were at a very vulnerable time. Next slide. The impact of the visitor policy was huge on patients, but also huge on us as providers, because we know how important it is for patients to have their families with them. And so Twitter was filled with thousands upon thousands of posts from patients as well as caregivers about the impact of this visitor policy and the inability to have visitors and family at the bedside. So Dr. Silver posted, "Last night I had to tell an elderly patient that they were going to die from COVID-19 and fast. There was nothing more we could do for them. They reached out and I held their hand for a while, and their only source of comfort in the world. Soon I had to let go as I had other patients that needed my help, what little help I could offer. This patient ended up dying alone, and there were no visitors allowed in the hospital." Imagine the feeling walking away from this person knowing death was coming for them and you were their last human contact, their last sense of hope and connection to this world. This will stick with me for a while. There is a moral injury there that is happening to providers having to witness this degree of suffering. So it is suffering above and beyond that caused by the disease and the illness, but also this human suffering that I don't think we've experienced in this way, whether it be on the patient side or the provider side. Luke is a nurse who describes, "A patient died the other night with me holding her hand because COVID-19 has prevented families from visiting their loved ones. Today, I sat with a patient and held their hand and cried as she was terminally extubated. This freaking sucks. And so these are not unique stories. And I'm sure everybody who has taken care of COVID patients has experienced this on some level. Next slide. Dr. McHugh mentioned a patient who, after she delivered her baby, thanked her for touching her. She said that since she'd become infected, people were afraid of her and wouldn't make eye contact, much less hold her hand. And so again, the importance of connection, the importance of having that support around people can't be understated. And the impact of its loss on patients can't be understated. I think it's important for us to recognize this level of suffering that patients are going through so that we can try and tend to it when we can. Next slide. There are often, under normal circumstances, barriers to family communication that have been highlighted or magnified by the pandemic. Family may be unavailable to talk during hours when we may be available. Family may not have internet access or a device capable of video conferencing. This, I naively did not realize how many patients in our Detroit area struggle with access to internet. Or they may have phones, but they aren't smartphones and they can't video conference. The patients may not have those devices. There may be language barriers. The other thing is family members or patients may have limited technological literacy, and this is particularly prevalent in our older population. So, there are patients who are in their 70s or 80s, they have the smartphone, but they're not really sure how to use it, or they don't know how to video conference through it. And so our awareness of these barriers is extremely important to be able to help kind of bridge that gap. Next slide. So what are some communication strategies or best practices? And this is by no means a comprehensive list, but these are some suggestions, some that we implemented, many that we implemented in our own institution that we found helpful. So encouraging patients and families to call, text, or video conference one another, facilitate delivery of communication devices from the family to the patient. The family can't come in, and so we have to find a system that works to be able to deliver those things in a timely fashion, including the charging devices. Help patients record and send audio or video or written messages to their families. Encourage patients to journal when they can. Our hospital provided tablets in order for each individual ICU. At first, we were using our own devices, placing them in biohazard bags and taking them in and then sterilizing them when we came out. And so it was recognized that there was a need for us to be able to easily and readily provide that video conferencing for patients. And so considering buying whatever devices for your institution to help facilitate that is really important. Request pastoral care support or facilitate video conferencing service with external faith leaders. And so just because they can't come visit doesn't mean that we can't facilitate that communication and provide comfort for families and patients in that way. Customizing the patient's environment. And so, there are patients who sometimes in the ICU, especially if they're having a slightly longer stay, will notice traditionally family will bring in pictures and drawings and things that are placed on the wall. And I think that was much more common with COVID patients, where their rooms would have pictures and blankets and whatever familiar things patients could connect with, and have that almost as a conduit with their loved ones. I emphasize to my resident and fellow teams that communication at baseline is essential with families, but now we didn't have the luxury of having them come to the ICU at some point during the day for us to be able to go meet with them and give them an update. And it's easy to miss calling people or to forget to call when you're caring for so many more patients than we usually are accustomed to caring for. But it was almost a rule that we had to connect with families at least once per day, preferably twice, once after rounds, once before they left for the day, to give them that update. Because I think what we also forget is many of these patients were dropped off by their families in the ER, and these patients walked into the hospital. And we are calling the families a few weeks later saying they are unlikely to survive. And we're talking about potentially withdrawing life support. And that, without witnessing that progression or that decline over time, there's a disconnect there for families and patients. And if you think of the amount of trust we are asking people to instill in us when we are making these recommendations to them and they haven't seen their loved ones, it's very important to make sure that we've done our job communicating and built that trust over time, because our role has become even more important and in supporting families and making these decisions. Again, this is not a comprehensive list, and we've had to be creative in making sure that we're connecting with patients and their families. But I think if there's one thing that I would like everyone to take away from this is being mindful of the impact that this has had on patients and families as well as us, and finding strategies to make sure that we are effectively communicating with patients and their families. Thank you.
Thank you. That was excellent and very moving. So I'd like to open this up for a panel discussion now. We have some questions from the audience, but I'm going to take a question of my own to start with. So for really everyone, we're in the middle of a third wave. Maybe can you count a fourth wave with the Thanksgiving that we all just had? What have we learned that we need to be doing going forward? What do you guys think that we should be focusing on over the next few weeks in your particular areas? What are the 2 or 3 things that we should be really paying attention to?
So I think one of the things that we're doing is, in the beginning, it was figuring out how we were going to ramp up, which units were going to be converted to COVID units first, how teams were going to be potentially redeployed. I know it's a little easier this time in the sense that those plans have already been developed and are in place. I think what we're focused on as well is how do we keep our non-COVID services, particularly on the outpatient side, still running as much as we possibly can while balancing the service demands that we know will go up on the inpatient side, so that we can make sure that we can still kind of provide the care that we need to for non-COVID patients. We know that there was an impact on those patient populations before, after COVID, because people delayed care. So how do we try and avoid making that happen?
I think what we're trying to do differently is really change people's schedules a little bit to give them time in between their runs in the hospital. So trying to take 4 or 5 days before you come back again after you've done a 7-day shift swing, so that people have time away from the hospital, can recover a little bit from what they've been through and go back in. This time there's a lot less help. We don't have as many people deployed to help us because people are trying to continue regular operations and of other services. So that's a little bit of a struggle. So really trying to focus on keeping people sane and dealing with the burnout, and also trying to keep the group very cohesive. We are meeting, agreeing on treatment plans. It's a little easier. We have some randomized control trials now that we can go by. So there isn't this back and forth about what treatment to give as much as there was before. So that's helped a lot, the unity within the division. And it's really just critical care this time, coming together. So that makes that a little bit easier as well.
Yeah, and everyone's getting hit, so it's not as if everyone can go running to New York and Seattle to help out, because we're all getting hit
Absolutely.
at the same time.
Yep.
And I would think from a medical education standpoint, I think there's 2 elements. One is, again, having having an eye on what educational opportunities a trainee may have missed in the previous academic year and making sure that there's an opportunity for them to go and get those educational rotations. Certainly because all of the other hospital operations are up and, not nearly as taxed or strained as they were the first time around. And it actually makes it easier for trainees to get those other clinical rotations outside of the medical ICU, which I think is incredibly important. And I think the other thing, again, the thing that keeps me up at night is always thinking about trainee wellness. I think, again, as I mentioned about psychological safety, I think our trainees in particular are hesitant to let us know when they are in need. When they're struggling. And so it becomes incredibly important to make sure that we assess that. I'm one of these people who goes day by day into the ICU and just kind of touches base with people just because I want to make sure that, when I hear that things are okay, that I can see it for myself. And more importantly, survey and surveil the needs of our trainees and get the resources that they need so that they feel comfortable in their environment, because there is a tremendous amount of moral distress that they have encountered. And making sure that we have an awareness of that is incredibly important, because again, they're not always willing to tell us when they are struggling. And so it is really up to us to make sure that we, keep them safe and keep them well.
Dr. Tatum, I was wondering if you could talk a little bit about medical students, just as a separately from residents and fellows. They're a little bit of a different population, and I know that some institutions are asking medical students to be more asynchronous and distance in their learning because of concerns about spreading COVID among staff, concerns about PPE shortages, and sometimes they get a little bit of a short shrift. So I wondered if you could speak about that a little bit.
Yes, I think they certainly did have an element of that, particularly in the first wave. And it was kind of an interesting dichotomy. There were certain places within the country, New York being one of them, where, medical students were being graduated early and coming into residency early, well, not early, but before all of their rotations were done so that they could start and help with workforce demands. Now the pendulum has swung the other way, and now there are already discussions about extension of training, at least for residency and or fellowship. And there's probably, again, some more discussion about what that looks like from the medical student perspective as well. So it's an interesting dichotomy, if you will. I think, again, with the sensitivity to what our trainees need, I think medical students in particular were very well protected the first time around. And we have to sort of gauge where that right level of protection comes from. I think now that, again, we have proper PPE, we have, well-established procedures for donning and doffing, we have systems in place where we can make sure that medical students in particular can keep themselves safe. I think it's less of an issue in terms of, keeping them completely away from clinical rotations, and is a much more easy to now have them, continue in their learning in a more synchronous and more in-person environment, clearly, than earlier this year.
Yeah, thank you for saying that. So, Dr. Hagab, what should we be doing with our visitation policies? Should we be, and if you ran the world, should we be lightening them up a little bit?
That's a really hard question.
I'm sorry to throw that at you then.
I think on the one hand,
you can phone a friend and ask one of the other doctors on the call.
I think on the one hand, again, the importance of patient-centeredness can't be overstated. But I think the worry is that, when you have positivity rates in the community that are as high as they are, and we already have a problem with PPE shortage, we have a problem with healthcare workers now. needing, to be quarantined because they're developing COVID and COVID positive, which is putting a huge strain on the workforce. I think we are still, from a resource standpoint, having to make that difficult decision and say that visitors, I think it's probably prudent to still maintain many of the restrictions that are currently in place. When the community positivity rates were low over the summer, those restrictions were loosened. And so it's not to say that that's not possible, and it's not to say that COVID patients won't ever be able to have visitors. But I do think that right now, with the surge that we're in, would not be the right time to loosen those restrictions.
Yeah. And I would definitely agree with that. We've had several instances where visitors have brought COVID to patients in the hospital.
Yeah.
So I think there's lots of reasons, unfortunately, when the community positivity is so high that you sort of have to.
Right.
Thank you. So we had a question about process improvement, and I know we talked a little bit about huddling and it sounds like, at least in New York, you did a tremendous amount of huddling and coordination. Oops, I muted myself. Do a tremendous amount of coordination every night to evaluate your current practices and where you need to move ventilators and staff and things like that. Are you still doing that? Is that something that's still going on, or you plan on doing in the next surge?
We've had lots of time between and to go over what we need to do and to be ready for this next wave that we're seeing now. So we've had time to sort of plan that out and shore up our resources and get more ventilators. So we are much better prepared this time around, given what we saw last time. So I'm hoping we never get to that point of having to do that again. But if we need to, we absolutely will. We're meeting on a regular basis and just talking about supplies and making sure that everybody knows what we have. But we are certainly not at the point where we were last time, where we are limited in resource and we are just struggling to get through the day every day. So there's a big difference. We've had some time, and the availability of things has loosened up a little bit during that time period. So as we go into this, we're better prepared.
So if you could go back in time and give yourself some advice, what would you have given yourself in March? Anyone?
I think the fear was the biggest thing for us at that time. We were afraid we were all going to get sick. So I think telling myself that proper PPE works and to be confident in that would have saved a lot of stress and anxiety back then. So knowing that and feeling secure coming to work would have been very helpful. So that would be the one big thing I would say. And that would change a lot of other things around me, knowing that.
I think that's a great point. I think that, certainly people in the healthcare setting who wear proper PPE and treat everyone we meet as if they've got COVID, we're less afraid of getting it because we know that the precautions that we take in terms of masking and personal hygiene work. So, we're, I think, a little less afraid than, maybe some of people in the community.
Yeah, I thank you for mentioning that, Mangala, because I think I acknowledging the fear that we all had is really important. And I think you're right. When I gauge my level of anxiety right now going into another anticipated big surge, I think even though potentially this surge we're expecting maybe bigger than the first one, the anxiety is not of the same level, I think, because there isn't as much fear personally and for my colleagues and for those around me in terms of, our risk. And I think, and in all fairness, I think we know more, right? What we know more now about the fact that our PPE works and what level of PPE is appropriate. And there was a lot of misinformation and a lot of misguidance in the beginning that certainly didn't help with a lot of the anxiety that we had. I think our PPE stocks are better now than they were, and so fingers crossed they stay that way. But I think that's another big factor.
Yeah.
Dr. Tatum, did you want to chime in on what you would tell yourself?
Sure. I mean, I would remind myself, that there are many things and many challenges that are up ahead, but, again, with good planning and a good, clear mind focused on it, you can get through it. I think, our teams did extraordinary work. I think the communication plans within our institution and again across institutions was phenomenal and really helped us be very effective. I think not only would I have better acknowledged my anxiety, but I think I probably also would have recognized that I thought I knew more than I actually did. And I think the greatest lesson for me in this whole pandemic was being able to, again, model to my learners that we don't know much of anything. And so if there's ever a time for them to know that it is okay not to know and to be comfortable in saying they don't know something, they don't know how to approach a problem, but they need help, I think was probably one of the greatest lessons, helping them actually see that not everybody has all the answers, even though they may think others do. And getting comfortable with not knowing the answers, but being diligent about using the information we do know and treating patients with the science and the evidence that we do know works is the right way to go. I think that was an incredibly important lesson for all of us.
I'd like to add one thing. I think being better prepared to handle the PTSD and burnout of our staff, training people in psychological first aid, and being able to deploy teams to, resident teams who are dealing with, patient dying at, one after the other. I mean, that takes a toll on people. I think the nurses were under enormous stress, and there are many across the country who have left medicine right after having had to deal with that. And I think we underestimate the impact that this is going to have on us long term. And I think being better prepared for that. And I don't know that you can ever really prepare for something like this unless you've experienced it. But in retrospect, and what I hope we can accomplish with this upcoming surge is having those processes and programs in place to make sure that we're taking care of our own as well.
And I'll just add that some self-compassion, that we really did the best we can. And although we feel like every patient death is a failure, that some self-compassion, that we tried to do the best we could in the circumstances that we were given. I would tell myself that.
I think that's a great way to conclude. I've been very impressed with how everyone has risen to this occasion across the country, and particularly the teams at the bedside in terms of the nurses and the respiratory therapists and the physicians and the residents and the environmental staff, who frequently doesn't get mentioned at all, but is the backbone of most institutions. We're all a big team, and we've done a great job getting through this, and together we'll get through it again. So I want to thank our panelists. This has been a really great discussion. I was honored to lead such an august group of doctors. Thank you all for joining us today. And thank you to those of us who listened. I appreciate your time. And please tune in next week, when we'll be talking about specifics about bedside care and treatments, and what we've learned about what's the best way to treat patients with COVID over the last year. So thank you very much, all.
Thank you.
Thank you.
Take care.